I thought I'd kick off with a picture of sunny Bath, just to show it is also sunny down south. On we go. There's my disclosures. So I thought I'd use a bit of AI to do my lectures for me, save me having to bother. And this is what it came up with. I put in Glasgow nuclear medicine clinical highlights. It's not bad. Gamma camera diagnostics, radiopharmaceuticals, therapy, and oncology. I think it summed it up pretty well. And these are, I think, the major themes that we see emerging in nuclear medicine at the moment, and maybe why the conference has such high attendance. I also thought I'd just try a bit of AI just to see what it thought Jeremy Clarkson would say about the SEC. And this holds pretty true. The first time I came here, we were sort of scouting the venue, and there was a Taylor Swift impersonators conference going on. And it'd be very easy to nip out into the wrong session. So if anyone comes back with some new kind of ink work, we'll know they've been in the Tattoo Expo. Anyway, right. So I thought I would jump around the nation and highlight the papers that are proffered that I thought were interesting, both in PET-CT and in traditional STEAM nuclear medicine. And I thought, given we're in Glasgow, it might be fitting to start here in Glasgow. I thought this was an interesting study using cardiac MIBG, a tracer that we've had for years. And as I'm sure you all know, it's been repurposed to try and help us understand movement disorders and dementia. So the Glasgow group, they looked at a number of patients who they had DAT scanned and looked at what their ultimate diagnosis was. And you can see dementia with Lewy bodies was the most prevalent. Then uncertain was quite prevalent too, and they've got a bit of idiopathic Parkinson's disease, some multi-system atrophy, and some psychiatric disorders in there. And they were wondering, could cardiac MIBG help them differentiate these groups? Because on DAT scan, they look relatively similar. Just a little background there. Essentially, your cardiac MIBG is showing your sympathetic neurons, and in idiopathic Parkinson's disease, you get reduced cardiac sympathetics, whereas it's maintained in multi-system atrophy and progressive supranuclear palsy. And so, in theory, you might be able to differentiate those pathologies. So they did a kind of pilot study and to see whether they can use this technique in a meaningful way in clinical practice. So I would commend you to go to this session and discover the answer, but I think this is a interesting use of a tracer, which some of us will be using for this purpose already, but it's just interesting to see how they've got on. And just brought a case example here to show you, so you can see the top there, the DAT scan. You wouldn't need to go on a course to learn how to report that. I think we'd agree that's probably a little bit abnormal. If there were ever dots, those are them, right? But what's interesting is you look at the heart to mediastinal ratio, and there's lots of uptake in the heart, and so this would support a diagnosis of MSA over IPD. So you can see how it would work. So I would pop along to that. Now we're flying south to UCL. So it's good that you can do that on the plane, so it would be quite easy to do. And over in UCL, they're looking at 18 FDG, looking at patients who are being treated for breast cancer with CDK4/6 inhibitors. And what they're interested in is, does the mean tumor volume, as a concept that you can isolate on PET-CT, does that have a prognostic significance in reporting these scans? And so there isn't an evidence base in these CDK4/6 inhibitors, and so they are looking to build one and discover whether this is going to be useful. It's been useful in lymphoma, but will it be useful in breast cancer? So again, I haven't revealed the answers. Ian Armstrong gave us a very strong-worded direction, and I'm not allowed to reveal any answers just to make sure you have to go to the sessions. All right. So, but I would pop along to that and find out. Back to Scotland. And I've got David on here. I'm not trying to flatter the host. But I thought this was an interesting topic and something we probably have all struggled with. If you report PSMA PET-CT, you've got an issue of non-specific binding, particularly with the 1007 tracer, the fluorinated tracer, whether you're getting non-specific bone uptake or have you got bone metastasis. Clearly difficult for us, even more difficult for the patients living with the uncertainty. So you can see on your left, we've got physiological distribution of tracer in the skeleton there. The next image in the middle shows some equivocal uptake in the right iliac blade. And the third image shows you a definite bone metastasis in the right iliac blade. And the problem is that middle group, what do you do? How do you report it? And how do you prognosticate? And so what they've done is they have followed up 150 patients with their large cohort. We see how much work they do here. And they have some lessons about what these mean. So again, I think it's a great session to go along to and to take away their learning. Certainly help my reporting. Back to London again. You see we're sort of oscillating across the country. So we're here at King's College in Glasgow and St Thomas's. They're very lucky to have 2 long axial field of view scanners. I opened RadMag this week, and someone was looking very pleased from Siemens, sort of standing there with 2 scanners. I thought it was, a good picture. And so they're making good use of this. And what they've been looking at is using the other fluorinated PSMA tracer, DCFPYL. Does it perform better in a long field of view scanner? And so what they did was they've taken 2 cohorts of patients, matched, put half of them through a traditional field of view or short field of view, and half through a long field of view, measured, reported them in a qualitative and quantitative way, and they've got some beautiful pictures, and I would commend that you go to that to find out whether you should buy one. I asked Gary Cook before this session if you had, 12 million quid, should you buy 3 traditional scanners or 1 long field of view? And he said, the paper's already been published, you should buy 1 long field of view. So you heard it here, so we all should be getting these. Now, this piqued my interest. So now, rather than going all the way back to Scotland, we're stopping off at Hull on the way up. And this is a problem we're always facing, is how do you differentiate sarcoidosis from lymphoma on PET-CT? They have very similar appearances, and if you get it wrong, it can really be devastating for the patient management because the patient ends up being misstaged. So I've got some pictures here to show you, hopefully. So they evaluated 97 cases, 59 of sarcoid, so that's a lot of sarcoid cases there, 38 of lymphoma, and looked at their differences. And you can see here that top picture, that's sarcoid, and you can see all of that hilar and subcarinal lymphadenopathy, and there we've got lymphoma with something going on in the liver, and it looks like the pancreas too. And so they looked at these 9 parameters and have come up with some lessons that we can learn to differentiate them. So I've seen cases where patients have been misdiagnosed with stage 4 cancers when in fact they've had coexistent sarcoid. And it's something that we always should think about, but it's not always as easy to identify as it sounds. So I think this will be a really useful session, and if you report PET-CT, you probably ought to go to that. And now we've flown back down south to my neighbours in University Hospitals Bristol, and what they're interested in is amyloid DPD. So we all know that this is a really useful technique. I think the last 5 years we've been doing a lot more of this. People noticed that with this tracer you can determine amyloid deposition in the heart. It's traditionally graded with the Pellegrini scale, so it's cardiac amyloidosis. You've got a couple of types. You've got the light chain, which is a rare type, and then the ATTR familial wild type, which is a common type. So misfolding of the amyloid protein deposits in the myocardium, the heart muscle, and you can see it on a scan. And we've got nice pictorial there showing these Pellegrini stages. I'm pretty sure the Pellegrini stages are established really on a kind of coronal MIP in traditional bone scan, but you can essentially reapply them here in SPECT. And so we got 0, which is where you got no uptake, 1 where you've got uptake in the heart but not as much as the rib, 2 same in the heart, same in the rib, 3 more in the heart than the rib. Now the thing is, these Pellegrini stages don't necessarily have brilliant clinical correlation and are a little bit arbitrary. And so this team are looking at, can you quantify the tracer uptake in the myocardium? Would that quantification be useful? So I won't give you the answer, but I think that's an interesting concept and something we should be thinking about. And it's definitely a theme in nuclear medicine. We see more and more quantification And it's just making use of that quantification. Just because we can measure it doesn't mean it is useful, but we should definitely be looking at the things we can measure to see can we use them and do they make an impact in clinical practice. So I think, that is the end. So I leave you with a picture of the armadillo or a spaceship or even the Sydney Opera House. I hope you have a brilliant time. I think the program is really exciting. I'm looking forward to going to the sessions myself, and I hope to see you all around. Thank you.